Okay, well, we had a workshop yesterday and we had some questions kind of come up. So when you talked a lot about stem cell transplant, kind of planning for it. I know you do a lot of transplant. If you're considering going to transplant, can you talk about stem cell collection, whether you are or are not planning on that? Do you go ahead and do that even in this age of new immunotherapies? Do you just collect when you have a planned transplant to go through, or what's the strategy there?
Start. I think definitely if you're transplant eligible, you should, I think based on the data I showed.
Just put it closer.
Oh, okay. You should definitely collect. And the process is basically shots. First of all, you want to debulk the disease initially. So if the marrow initially in a newly diagnosed patient is like 80, 90% myeloma, you're not going to get as good a collection. So you do a few cycles of chemotherapy. I think it is important not to do too many cycles of chemotherapy. One of the downsides I didn't get into is we think too much daratumumab with prolonged Revlimid or lenalidomide can impact the ability to collect adequately. So probably you should collect within four to 6 cycles, closer to 4 if you're having a good response. Radiation also, keep in mind, can impact stem cell collection. So sometimes I've seen patients in the community get radiated, especially to large areas of the spine or pelvis, can also impact the collection. But once you've collected those cells, they're good for a long time. And the collection's typically outpatient with shots daily to rev up the production of your stem cells. And then you get a catheter. You may need a catheter. Sometimes you can get from a peripheral vein, but a catheter goes in with local anesthesia if you need it. And then you get connected to like a dialysis type machine where your blood is filtered, and then we take out the cells, the rest goes back. In terms of your question, I think I'm curious to hear what my colleagues think. I actually have been collecting more aggressively for young patients because we didn't, and I'm sure Dr. Verdejo will talk more about this with the side effects of CAR T, is some patients do have prolonged cytopenias or low blood counts. And it's nice to have a little bit of stem cells on reserve to be able to resuscitate that marrow. And it also is useful, even if you, again, I think the data supports, and I'm curious, we should actually see what these guys think about transplant too in terms of timing. But there are also, you can use this transplant also in a relapsed patient as a bridge to getting to, say, clinical trial. So for example, if somebody has very low blood counts, that's prohibitive from entering a clinical trial. It's a catch-22. You have too much myeloma to get onto the study, but you can't get onto the study because you have too much, how do you get rid of the myeloma? So there also a salvage or second auto transplant can be helpful to improve the counts, but
yes.
Go ahead and collect.
So it's interesting because, we were having these discussions a lot, and actually there's some big centers. So normally when you get stem cells collected, if you are transplant eligible, usually we collect for at least 2 transplants, right? That's what we usually tell you. We're thinking 1 transplant now, and then like Dr. Chari suggested, maybe if you do really well and stay in remission for a long time, sometimes a second transplant may be helpful. But the truth is the majority of patients, if you look, who store their cells never get that second transplant. It's actually a very small percentage. And in the big trial that he talked about, determination in the US, the majority of patients that defer transplant, was it like 20%? Only 20% of those patients, and the intention was when they relapse that they would get their transplant. Only 20% of patients actually got a transplant. So at least in the US, we don't seem to be doing that many late transplants. And so actually a lot of centers had gone to the idea of why collect for 2, where we have too many, we don't have storage space and we're just going to do 1. But then CAR Ts happened and all these therapies started working for so long. And then we started getting into trouble, like what he said, where people were not recovering the blood counts, etc. And guess what? Having those stored cells was really helpful because it restores back your bone marrow. So yes, the answer is yes.
I guess 2 things, though. I would say the groups of patients I'm collecting more. There's certainly younger patients and some people certainly deferring transplant for a variety of reasons. There's 2 things that would be clear. You still have to do all the same testing as if you were going to transplant. And to Dr. Chari's point, sometimes most people, to be honest, especially if you're trying to collect for 2 transplants, you need to put a catheter in because it's very hard to use your veins for more than like 1 day in terms of collecting cells. So I guess that's the first thing. The group of people where we're collecting and storing less tends to be sort of what Dr. Chari said this morning, people age 70 and higher, and in part because of the data of the study he showed, that Maya study, using daratumumab up front plus lenalidomide and dex, the median, so what we call length of remission, hasn't been reached. So most people are staying in very long remissions with that regimen. And if you're staying in remission 5-6 years and you started at age 71, you're closer to 80 by that point. And at that point, you've only had one relapse. There's a lot of other choices. So, less and less, in terms of for that age group. I think maybe what we'll talk about later with Dr. Bardehar is the question, what is your age limit for CAR T cells? Are there patients where you would think about doing CAR T, but you wouldn't do transplant? So those are, I think, some of the things we all talk about now.
You want to weigh in on that? Just do you collect? That was the
Yeah,
question.
got it.
Uh-huh.
So yeah, I think for most of my patients, we do transplant. Again, I told you 50% of my patients are high risk. So it depends on that risk. Our older patients are the ones that maybe I don't collect on. And in the relapse refractory setting, just adding to what I think you guys were saying, there's a couple of patients that I have actually done a second transplant on because we were trying to wait until we could get bispecifics or CAR Ts and other things coming down the road. And we've been able to at least keep their disease controlled until we can get them on. So very few times that I've used it, but yeah, I think we've had one patient where we've given stem cells to, we've given one patient stem cells once their counts were low, but for most patients, the stored stem cells, we don't use them, but we collect still.
Okay. And I think that's so interesting because I think people would not have thought about using these collected stem cells to boost after CAR T or something. That's kind of a new thing that everyone's hearing.
I mean, it's not common though. I do want to say it's not a routine thing at all. I mean, I can think of maybe twice that we've done it.
Yeah. So 1, 2, handful. Yeah.
Yeah. But just it might be just nice to have that in the bank. Yeah.
It
Yeah.
is.
Okay. Another thing we talked about yesterday a little bit in the workshop was MRD testing. So can you address, because we had a lot of patients kind of weighing in and saying, well, I kind of asked my doctor about MRD testing, but they're pushing back on me and not wanting to do it. Or, so do you do MRD testing on a regular basis? Do you get the baseline when someone's newly diagnosed? Are you preferring flow versus the NGS adaptive test? Like, how do you use MRD testing in your clinic?
I can start. So for us, we, as patients come in, when we do that first bone marrow, we are doing the next generation sequencing to have that, clone that we know. And for us at MD Anderson, we do both. We actually have our own flow based. So we do our flow, which is 10 to the -5th, and why this matters. And then the next generation is 10 to the -6. So the lower that number, that means there's more cells we've looked at to make sure there's not myeloma. So 10 to the -6 MRD negativity means a lot more than 10 to the -5th, and just tells that we were able to look at more cells. So we look at it. I don't do it routinely for all patients, but anytime I do a bone marrow, I'll test. And usually when I do bone marrows for our standard risk patients is anytime I'm looking for a response to say, can I potentially decrease therapy or in clinical trials? I don't do them as much, but my high risk patients, I tend to do bone marrows more frequently just to keep a closer eye on those clones because I don't trust the labs as I have a lot of patients who will go into where they don't make proteins anymore or things like that. Those are the type of patients I tend to do more bone marrows on to look for this much more. I think MRD testing is a great tool for us to say, okay, where are you right now? As of right now, it's still a prognostic marker, and we don't really change therapy for most patients based on that. But trials are ongoing that hopefully will become a predictive marker. So can I stop maintenance in patients who are MRD negative, right? And hopefully we'll have that data really soon to say, oh, we should be doing this for all patients. But right now it's really a handful wherever I use that.
So we do it by next gen sequencing. So we send all the samples to Seattle. So I think the challenge with that is we don't get a lot of patients newly diagnosed. Most people have their initial bone marrow somewhere else. And so you need that initial bone marrow biopsy sample. I mean, we can get it. It just takes a little while to track it down at whatever hospital has it. And, so that's the first part of it is just remembering that we tend to do it a lot more now in people after they've had their stem cell transplant because of, to what Karina mentioned, some of the data is prognostic, and also in the future likely will be sort of another decision point. So I guess we're all very data driven. It's just the more data you have, the more it can help you with decision making. Not to say sometimes it can be confusing. These aren't perfect tests. You have to look at how many cells did you get? You know, an MRD test may be 0, but if you got very few cells, it doesn't mean anything. So, you know, there are challenges. We're also eventually going to move away from it because again, it's a bone marrow based test. You know, the issue is if you can do it from the blood, and that's really the future. Looking at circulating tumor cells, looking at DNA in the blood as a marker. That's really where we want to be.
I agree with it's a tool and it's prognostic as opposed to predictive. And to that point, the way to explain that, if you talk to a medical student, you say like they want to do a test, the response is, how is it going to change your management, right? Because if you're going to do the test, positive should do something, negative should do something. We don't have that level of data yet. And so I think right now it just says who's going to do better, who's going to do worse, which is nice to know. But I think the other things I would add is that the most important endpoint in clinical trials is overall survival. Are patients living longer? That takes a long time. Next would be progression-free survival, also going to take a long time. So then how do we advance science? Because if your DARA Revlimid Dex is over 5 years, if you want to do better than that, is every study going to have 5-year readout? So that's where this test belongs, in these kind of early, newly diagnosed settings where it's impossible and prohibitive to follow patients that long to advance science, which is, again, as Dr. Berdea said, it's a great thing that it's getting harder and harder to show these benefits. But I also think we shouldn't put too much weight into it. It is one tool. In the same way that if somebody had a VGPR, which is like a 90% reduction versus a complete response and it's completely gone, we're not changing the management on that, right? It's not like, oh, you're CR, we can stop therapy. This is just another tool. And I think to really emphasize that myeloma can exist outside the marrow. So if you have a crappy bone marrow, it was mainly blood, you're making a decision on a crappy sample. If you have myeloma outside that bone marrow, you're making a bad decision. If you have myeloma in the blood or urine, that's still detectable. So people put MRD in this mystical basket, like it's this magical test. It's just one more tool. And I think some of the, especially in the community doctor side too, they think of this as like leukemia. Like CML is a great example of all you need is a blood test and you're good, right? Myeloma is a blend of leukemias and solid tumors. So it's dangerous to be simplifying this into this one test. And the last point I would make is that you need it to be sustained if you're going to start making decisions. And a good example is one MRD at one time point being negative is meaningless if you don't sustain it for at least 6 to 12 months. And a good example of that is this study called the Forte study, which at initial follow-up at 1 year, it said, okay, only high-risk patients need transplant based on MRD testing. With an extra year or two of follow-up, everybody benefited from transplant, right? So that shows the fallacy. And if you had made decisions on that test, you would have been making the wrong decision. So right now, I would say it belongs in clinical trials to help us make decisions about less heavily treated patients at the bedside. To close, I would just say I only use it in 2 settings, whereas if it's a low-risk patient who's now 5 years out on chemo and doing great and having some side effects, then it makes us feel better about discontinuing therapy. And at the other extreme, a very high-risk patient whom you're still seeing that positive clone, you're not going to decrease your dose intensity and you think about maybe intensifying. But again, we don't have data yet. And Dr. Krishnan's leading a trial to discuss that specific question.
So I agree with everything everyone said, and you stole my last one I was going to say. So it is not, I don't think it's ready for prime time, just because, again, we don't know what to do with that information, but it's nice to have. So if you can get it, I think you should. But if you don't, it's not the end of the world. And we have even bigger problem than what Dr. Krishna said, is that at least in Tennessee, when you get a bone marrow biopsy, it really depends on the pathologist, and a lot of them do not save fresh tissue. So once they decalcify the bone, that we can't run those diagnostic tests anymore. So even if you try to get it, it's no longer available. So it's really educating the pathologist about sort of kind of what kind of sampling they need to be storing for potential inquiries. We have a lot of problems in Tennessee. But the only other thing I would say is I agree with, the side effects. So if you're MRD negative and you're having a lot of issues, it might help us kind of discontinue therapy or at least make us feel better about it. But the other one I would say is the other extreme. So as we're learning more and more, for example, in CAR-Ts, there's some new data coming out that if you do not reach MRD negativity by even 1 month after the CAR-T, that you're probably not going to stay in remission that much longer. So it's very possible that in that scenario, that may be one of those tests that will help you decide if you need to add something else after the CAR-T, for example. So it's still all evolving, but it's a nice tool.
Yeah, we just did an MRD survey asking patients, like, are you familiar with it? Have you had it? Did your doctor talk to you about it and all that? And so we found like 25% of patients who thought they'd had it, didn't have it, and, or didn't have it and thought they had, like the opposite. So we just need more MRD education, I think.
Though I'm going to push back a little, Dr. Chari's comment about we don't change therapy, because I don't think, at least it's not always true. I mean, you did already make the point that you sometimes will discontinue therapy. There are cases where I've had a couple patients where there's been a big change in their MRD and they had high risk disease. So you do know that that's a harbinger that, you're just maybe catching it much earlier. And in those cases, I have changed therapy. And so I don't know if other people have done that.
She's 10 years ahead of all of us.
Okay. Well, I know that Greg has given me time, but I'm going to have one more question. So I know you can't put me up here in a panel and then ask me 2 questions. Okay. So Dr. Chari, you talked about DARA RVD, so at the recent International Myeloma Society meeting, there was a presentation that talked about DARA RVD using this quad therapy up front, better outcomes. There were a lot of US doctors that kind of said, we're here, like we're ready. You all said you're doing that. And then some of the European doctors pushed back and said, no, we need a phase 3 trial, which is going to take years, hundreds of patients, and a lot of money. So we kind of went back to our data and we found exact matches for the Griffin trial. And we just submitted like a late breaking abstract for ASH that had confirmatory data that showed, say similar results to the Griffin trial in the real world. So how can we jump forward, I guess, using real world evidence? Can we use that to help speed up approvals and bring daratumumab or other types of things? Like phase 3 trials are really expensive to run and they take a long time, like you said, with the readout when you're looking at progression-free survival. So how do you see real world evidence being used like that? That's just like one example.
It's a hard question. I'm glad you got that question.
No, it's a topic that I'm very passionate about because real world, if you look at the clinical trial data, depending on the study, anywhere from 10 to 70% of real world patients are not eligible for studies. So we don't appreciate how cherry picked these study patients are. You have to have pristine blood counts. You can't have any other medical problems. You have to have measurable myeloma, all of these things. And if the median age of myeloma is in the late 60s and 70s, people come to the table with heart disease, kidney disease, and you're excluding all of those patients, right? So but on the other hand, if we don't start with that population, you don't know if the safety issues are going to be due to the patient issues or the treatment issues, right? So if you do a bunch of treatments on very, very sick patients, you can't tease that apart. So clinical trials serve their purpose, but you need these confirmatory studies because, in fact, there's an FDA meeting with the coming up with the IMS this week, and some of the questions being asked are what are the right endpoints for the studies. And I think these the myeloma community has been criticized, like we get all of these drugs approved. This is true of carfilzomib, bortezomib, selinexor that are given at high doses twice weekly, and no one can do that. And then in the end, you have to reduce the dose. So why do we do these kinds of approvals, right? And that's my pet peeve. Like we should be looking, if you know that more than 10% of patients are getting reduced, why don't you just plan the reduction and not make everybody go through these side effects, right? It's silly. But to the real world issue, the The challenge of the real world is you don't control for all of those other variables, right? People may be getting different doses and schedules, and you don't know all the details of their myeloma. You're missing major prognostic information like staging, genetics. So then you get these outcomes that you don't really know what to make. So I would say real world should be complementary. And part of the VRD, DR that you started with is it's a regulatory question, right? So in Europe, ideally, the EMA will only approve for overall survival. PFS maybe, but not usually an earlier therapy. And part of that is you're going to give more, a lot of this is expense driven. Newly diagnosed patients are going to be on treatment longer, which confers more cost to the healthcare system. So that's why they scrutinize that. And then if you look at the US, RVD, which has been the default induction regimen for the last decade, was on the basis of a single arm study with 60 patients, right? So in the US, we can get away with a lot more. And that's partly why you're seeing that European American divide. It's cost driven and regulatory driven, not that they disagree with the practice. I bet you if you ask these European doctors, if you could give DVRD, would you? And they would probably say, yeah.
I wanted to add for CAR T, for instance, we have a lot of real world data that a group of, different, because most of us can't get CAR T, we're putting all that data together, and we were able to show at ASCO last year that of the patients getting ide-cel initially, 77% of those patients wouldn't have been on trial. So the majority of patients that got CAR T initially would have not been able to get on trial. Safety wise and response wise are actually very similar. So that we've gone back to the company now to say, hey, we need to open up the criteria for future trials, right? So again, as Dr. Chari said, when something's first in human, we want to make sure it's safe. That's the number one thing. But then once we have it, how can we make it more applicable for future trials to allow more patients on? So that complementary piece is really important. I think real world data helps drive that then too.
Yeah, we're going to run a 3-year CAR T study using HealthTree Cure Hub to kind of see differences, like what was the experience like, what was the, and all that. So what were the outcomes like? What's happening in the real world with patients who are getting it now commercially, Okay, well, I guess I'm getting the hook. So
one of the advantages of attending a roundtable live is that live questions get asked before online questions. So if you have some questions, please ask them. So does anybody have a good question for us to start out? Audrey, this gentleman here.
Can you hear me? Okay. I have a relative that has a very rare aggressive form of multiple myeloma. I'm just wondering, what does the maintenance look like? And is it different than, I guess, other patients with more aggressive cytogenetics?
So I think the question was, in a patient with high risk multiple myeloma, should the maintenance be different?
With a more rare aggressive form, does the maintenance look different?
Okay. So the short answer is yes. Unfortunately, patients who have high risk multiple myeloma, and those high risk usually means that either you have you're a stage 3, for example, versus a stage 1, or you have high risk mutations like 17p deletions and 414 and 1416. I think those were covered by somebody, I think. So we call that high risk multiple myeloma. And so, or sometimes sometimes it can be in a leukemic phase, or the cells are actually circulating, and that's also considered high risk multiple myeloma. So we know that patients with high risk disease don't do as well as patients with standard risk myeloma with the exact same therapy. And so usually when we have a high risk patient, we are trying to be more aggressive, and in particular with the maintenance therapies. So most people who get maintenance just get maybe Revlimid by itself, right, a low dose. Usually for high risk patients, if we can help it, we try to add at least one other drug, or maybe even 2 drugs. There was some data that we all quote from Emory, looking at patients getting both Velcade and Revlimid as maintenance, and those patients actually did almost as well as their standard risk group. So the answer is yes. So I would change the maintenance for a high risk patient.
No, I agree. I mean, I think we really use the chromosome changes, as Dr. Patel said this morning, the DNA in the cell. That's sort of how we define high risk. It's not really how you look at it under the microscope, but often people who have sort of what you alluded to, the question of, for example, plasmablastic myeloma, is when it changes you see under a microscope, but really often that type does have high risk chromosomes. So it would be the high risk chromosomes that would drive our decisions about treatment.
The only other thing I wanted to add is I think to broaden the discussion risk, I completely agree with the genomic discussion, but we should think about risk more broadly. So there's patient issues like older, frail patients are high risk. Patients with persistent kidney disease are high risk. Then there's the international stage high risk. There's the genetic high risk. And then to use the crystal ball question, one of my other pet peeves is I think we should stop doing photographs and look at movies. And what I mean by that is we conventionally think of risk when somebody's diagnosed, but we're now understanding that you can be a pretty standard risk patient, but if that patient relapses earlier than expected, that's also high risk, right? So risk can come in many different flavors. And all it means is that you don't settle for less, right? Risk means you're going to push harder and deeper to get these patients in long-term remission and keep them there and not back off and that's the last part, going back to the real world question. We see all of this pristine data from clinical trials. The gap in real world is dramatic, right? So there's a lot more treatment discontinuation in the real world. And both because of patients and doctors and nurses, everybody gets tired. But if it's a high-risk patient, you have to keep that patient on treatment to sustain that because it's not just one time point of, as I said, MRD negativity. Knock it down and keep it there.
The one thing I should say about the community and I think especially Dr. Patel, has kind of alluded to, she's the youngest in terms of practicing. I can remember when fish testing was very exotic and very few people did it. And why are we going to do it? We're not going to change anything. So I do think that in a good way, we are able through both myeloma doctors and myeloma patients to change thinking. And that's why I do think things such as MRD testing, for example, will get more and more widely disseminated in the future.
Yes, after CAR T therapy, do you have a different vaccine schedule than with other treatments?
Actually, that's a very good question. So CAR Ts are pretty new, right? So it's interesting because we're still sort of developing what is the optimal sort of prophylaxis. We talked about infections being a big problem after the CAR T period. So definitely the prophylaxis is a little bit more succinct in terms of what you should be doing. But the question about revaccination is an important one. And so we actually have a CAR T working group where we're kind of have like representatives from about 10 different CAR T programs. And we actually did a survey in terms of what they do for vaccination. And like Dr. Chari likes to say, you ask for myeloma doctors, you get 5 answers. We got 15 different responses. So there's no standard sort of revaccination. It is important though to vaccinate, and definitely, it's what are your risks for, right? So remember, there's no B cells. So encapsulated organisms are a big problem. So definitely you should be getting your pneumovax and get that whole series. Flu vaccine for sure. Usually we start about 3 months after the CAR T to kind of start the vaccine process. COVID, the recommendation is that you start the whole thing. You actually basically get the first 2 sort of prime doses, and then you get the new booster, not just one booster, for example. And then there are some of us that are doing sort of kind of revaccinating as we do after a stem cell transplant. So about a year after, kind of start the whole sort of childhood vaccination process.
I mean, I guess to your point about it's a work in progress, because we do revaccinate COVID, but I don't think we revaccinate with the whole series. We definitely do flu, and the other ones, it's been very ad hoc, and which is probably not good. The ASTCT, which is the American Society of Cellular Therapy, we are trying to have sort of guidelines and come to some agreement, but as Dr. Berdehar said, it's kind of evolving as the field grows and more people get CAR T cells.
Just add that I think the fludarabine cyclophosphamide conditioning, which is the chemo that's given before CAR T, is very immunosuppressive. So I think it is prudent. We at Mount Sinai, we wait 6 months because I think you need the immune system to recover. If you vaccinate too early, you're just pouring in water and the body won't mount the response, with the exception of COVID, because there's a time dependent issue, right? Like you can always give more and do the boosters. But also I would say recently we've really broadened our cellular therapy, both transplant and CAR T, and particularly in New York, because there's, as you know, there's variability in vaccination compliance in the population. And so there's polio and other things that are coming up. So we really have gone much, much broader with our vaccination strategies for both CAR Ts and transplant.
I have a question about initiation of therapy. So for the patients with smoldering myeloma, I keep hearing it's important to start therapy early. If you don't have high risk smoldering, but you are progressing. So my M protein went from 1 to 1.3 over a 3 to 4 month period. So the question is, how are you not high risk if your numbers are going up? I guess is, as the patient, I'm thinking, well, I'm progressing, I'm marching in that direction. So are there trials? What else can we do?
You would
And-
ask
and-
the
and-
controversial question.
No, it's okay.
So smoldering myeloma, just to kind of back up a little bit. So when we're talking about everything we've talked about here is active multiple myeloma, right? So if we all believe that if we could basically like test everybody at some point in our lives, someone who's going to develop active multiple myeloma, we probably would find the disease where you just find the protein without any myeloma cells, and we call that an MGUS, monoclonal gammopathy of uncertain significance. And then as you move forward, then the myeloma cells start to accumulate, but there's no damage to the body. They don't see causing harm, and we call that smoldering multiple myeloma. And then eventually the myeloma cells start causing damage, and we call that active multiple myeloma. And that's the one that we keep talking about.
Can you hold it closer, Dr. Verdejo?
Smoldering multiple myeloma comes in very different stages. So just like you were alluding, and what he said, it's not just a one time, right? So the problem with smoldering myeloma is that we know that eventually, if we all live to 200, we would probably all develop active multiple myeloma if we had smoldering myeloma. But the truth is, there's a large proportion of patients with smoldering multiple myeloma that will never develop active multiple myeloma. And so the standard of care has always been to observe smoldering myeloma, because once you start treatment, we're talking about continuous therapies, right? We're talking about therapies that are not necessarily benign. And so how do we determine when to intervene in the smoldering setting? And so there's actually a lot of research going on right now in terms of trying to stratify smoldering myeloma into sort of risks, just like we do with active myeloma. And so there is a particular subset of patients that are considered high-risk smoldering multiple myeloma that are defined as they have a 50% risk of developing active multiple myeloma in the next 2 years. So in those patients, there have been studies done that with some treatments, and again, these are sort of limited, like a 1-year duration of Revlimid, for example, with and without steroids, that you can show that you can decrease that progression to active multiple myeloma. The problem is the criteria used for high risk is actually quite complex, and it's a difficult sort of definition. And a lot of the studies themselves actually end up not including the same patients. And so they've been very difficult to interpret. And so that's sort of where I bet, again, if you ask the rest of us who treats high-risk active, high-risk smoldering myeloma versus who just watches it, you'll probably get both, because right now it's still controversial, or some people definitely would want to treat and people don't. But you wouldn't treat it as active multiple myeloma unless it actually meets the criteria for active multiple myeloma. Because again, remember, once you start that treatment, right now it's forever.
I think this is a case where also Dr. Cherry's analogy of the movie is very important. I think we actually have had some patients who've gone literally around the country to get opinions about their smoldering myeloma. And I think I can think of a case where someone fit the definition of high risk. By the time they went through on a couple of years of getting opinions, they had quote unquote high risk smoldering myeloma for over 2 years and hadn't progressed to active myeloma. So it kind of tells you need more than just one set of blood tests and one time point. And often it's that issue of looking over a period, and certainly doubling, is the number we tend to use of the M protein or the light chains within a 6-month period. And then that's probably another thing that we look at. So it's not just this absolute, okay, you're high risk. We need to start treating.
I think there's a lot of emotion and kind of. So let me give you an example. I have an educated PhD professor who had smoldering myeloma, who had been smoldering for over 2 years, and he wanted treatment, which by definition, if you've been smoldering for 2 years, you're not high risk. And he sought out treatment and was able to get into a clinical trial. Well, so what is this clinical trial asking and answering if you're allowing patients who've been smoldering for 2 years to participate? And so, and then when I find it really intellectually inappropriate when our colleagues will compare this disease to breast cancer and colon cancer, right? They're like, we see early stage breast and colon, we don't sit there and watch it. Why are we not treating? That's a very intellectually disingenuous statement, because a bone marrow cancer is not the same as a solid tumor. You can take out a lump in the breast. You can take out a polyp in the colon. You cannot take out the whole bone marrow. So if we want to talk about that, let's use analogies like lymphomas, myelodysplastic syndrome, leukemias, which are bone marrow-based disorders. And there's plenty of those conditions that we're not treating. So if we're going to have this conversation, let's at least agree on what we're talking about. And then there's also, let me open up the hood under what's happening here. There is a smoldering myeloma mafia that some physicians have. And listen, I maintain equipoise. I'm happy to treat this, but I want data. And you should know that there's 2 large published studies, one in New England, one in JCO, both of our highest impact journals, and many people are not changing practice. So you should ask, if high impact publications are not changing the way physicians practice, why is that? And part of it is, if you're going to treat smoldering, you have to get the risk stratification correct. And the slim crab criteria, the background to that was that we agreed in the myeloma community that if we can predict smoldering myeloma progression at 80% or higher in 2 years, which we all agree, we have amazing therapies. Why are we sitting on patients and letting them get crab symptoms, right? I agree with that. But 80% was the cutoff, right? And so let's look at that slim crab criteria, which I'm sure you've heard about, but the slim, for example, light chain ratio greater than 100. In the initial studies, it was 80+% progression at 2 years. In our data set, it was 44%. And the only prospective study, it was 30%. And that's coming from Europe. So when we submitted our journal, this paper, the editor, Blood, was great. And he said, oh, I really loved your paper. And it was reviewed very favorably. But one of the reviewers said, if this gets published, it's going to create confusion in the field. So since when in science do we not publish something because it doesn't match what other people want? And so this is the under the hood story, that there is this mafia of people that really want to treat smoldering, and they've made a career out of it, which I don't, I'm happy to jump on board, but show me the data, right? Show me that. And so that second paper in JCO that just came out, which is a 100-patient randomized study, the only patients that benefited was the high risk, which was 25 patients in each arm. No one's changing global practice on the basis of a 25-patient randomized study. And this highlights the problem with smoldering myeloma. You have to get the risk stratification correct. And the final point I'd make is, if you take newly diagnosed myeloma, because the flip side of this question, how long has a newly diagnosed myeloma been having myeloma, right? We all want to know that. And patients ask that, how long have I had it? It's hard to answer that question because no primary care doctor is doing SPEPs, UPEPs, light chains. But thanks to the participation of our vets, they participated in a study, and this was published in Blood, and newly diagnosed vets had banked specimens. So if you go back in time, 1 year prior to the diagnosis, 100% of patients had detectable protein. 10 years prior to the diagnosis, 80% had detectable proteins. So what that means is that the vast majority of myeloma patients have had this for a long time and did not have any symptoms, right? And so this goes back to my starting point, which is there's a lot of anxiety. No one's dismissing that it's anxiety provoking to be sitting on something and watching it go up, but that's the natural history. And if we're going to intervene, we have to be prepared to show that data, because Revlimid, 50% of patients discontinued it. They stopped and had side effects. So we have to be, if you don't get the modeling correct, if you don't get the statistics correct, you get 2 large studies that have not changed practice. So I think we need better data. And I encourage all my patients with smoldering to participate in studies to generate that data.
He doesn't feel strongly about this.
Greg will be providing security for Dr. Chari for this smoldering mafia.
this is a pretty practical question. I was really thrilled to see the four of you agreed on the value of quad therapy up front, and shocked that the uptake in the community was only 8%. I had not seen that statistic. And then thinking about 80+% of the care is delivered in the community. What are your thoughts, real practical, about the value and when and how patients should incorporate expertise from people like yourselves in the creation of their treatment plan that factors in those things, your personal, your disease, your treatment history? When should that happen? If you're high risk smoldering, at newly diagnosed, and how do you work with the local hemonc to make sure that there's a team type of approach? I know a lot of people are afraid, they don't want to insult their local hemonc, but let's be real practical. We know the value of your expertise, and it's become real clear already this morning. How do you bring somebody like that into your plan in a real world way?
I guess the one point I did want to make about the quad therapy, we certainly use it, but having said that, I don't want people to feel if they're on triplet therapy, oh my God, I need to go run to my doctor, because we certainly see cases, people come to us for transplant, they've had triplet therapy, they've gone in remission, you know, so we don't necessarily suddenly say, oh, now we need to add something. So I don't want to overly alarm people too. So I'll leave it at that, and I'll let these guys talk about, I mean, because I think for the Southern California patients, you do know that we work very closely with the community physicians. We're very lucky to have great community physicians. I don't think you need to drive 50 miles to get a shot of Darzalex. You can make your life easier for sure.
Yeah, no, so I'm in a little bit different situation than these guys. So I actually I'm a partner in this big group in Tennessee, Middle Tennessee, called Tennessee Oncology. There's about 120 docs, and so they're scattered throughout Tennessee. And so we call it the spoken wheel. So basically, I feel like I touch every myeloma patient or hear about every myeloma patient. The docs very quickly will call me and ask questions, and then I get involved. And also, we develop the protocol, sort of the guidelines in terms of what treatments are available to them, so that a doctor in Murfreesboro, an hour away, when they see that newly diagnosed patient, after we discuss, they can actually just go in and Darzalex, Revlimid, Velcade comes up, and they can, that's sort of kind of one of their options. And so I think that's what needs to happen, is sort of, and that's what's happening now. So I think as that, it should be as early as possible, basically. So upon diagnosis, whether it's smoldering, whether even in MCAS sometimes, right? So you should have that second opinion early, because your local doctor is actually more than happy to get help. They don't necessarily want to read all these studies and so forth. I've never had a doctor like, get mad at me because I suggested you should do this. So actually, so you're not going to offend your doctor. Your doctor actually is very happy that you actually did it. Now, of course, if you go and get 20 opinions and then they're confused, everybody's very confused, that can be a little bit difficult. But definitely, at least that one-time specialist is important. And then keeping the person involved. So if things are not going according to plan, there's a change, or something different is happening, or the doctor's talking about changing therapy, that's when you should probably go back and just kind of get a reassessment and just make sure everything's okay.
So there was a study that showed that the patients treated at academic larger centers have double the survival of patients who don't. Now, that's not a completely fair way of answering that question, because of course, not everybody has the health, time, ability, resources to get to an academic medical center. So of course, the patients that are seeing us are not the same as the really sick, fragile patients in the community. So you can't do that direct comparison. But I do think that it speaks to the complexity. You saw, we keep adding drugs to our arsenal, right? So how are you going to thoughtfully sequence all of these? I haven't kept up with any other disease other than myeloma. So I don't know how our community, but we need both, right? Because everybody can't be a specialist. But I think the compromise is that everybody should see a myeloma specialist. And it's harder to get a new patient appointment. So get it when it's not a crisis. So get in there. You can decide whether you need to go in every 3 months, every year, depending on how active your disease is, and at major junctures of decision-making, side effects or disease progression, right? That's a good time to go visit. And lastly, I would say, if a doctor has a problem with you getting a second opinion, you need a new doctor. And I have told my own patients, I had a patient who did not want to get what I recommended. I said, please go get a second opinion. You don't have to go with what I say. I want you to feel empowered and feel confident in your own decision-making, because we all know control is a large part of how you do in your disease, right? So having that control of ownership of like, I don't have to do this because this person said that, and getting that, it'll give you more confidence in going forward. So do not feel shy about getting a second opinion.
I think the other thing, to Greg's point earlier about what we talk about, I mean, we call each other up. I talked about a case with rising MRD. I called up a couple of my colleagues, said, hey, what would you do? This is what I'm thinking. So often we're getting second opinions among ourselves. I guess I'd be interested to hear what these guys think, because often what we're seeing more and more now is patients getting 4, 5 different opinions. And I honestly think that it probably doesn't help. It makes it just more confusing unless you're trying to say, okay, 3 people said this, because it's like cooking. A lot of times there's nuances that are not all or opinion driven, but there's no right answer. And I don't know, especially in New York, I think there's so many myeloma centers and they're close by. You can just hop from one to the other.
New York? I don't know about New York.
You have Tennessee problems. Yeah. I agree. I mean, I think you need a few like 2, 3 max, but I don't know what else you're gaining, and you're just kind of, and again, if those patients who are doing that are often very anxious, and the treatment of anxiety is not more opinions, right? It's to make a decision. So I think it just adds to that emotional conundrum, I think. It depends on the state, because each state has different licensure guidelines. So some of us, I have now licenses for several states, but not all of them. So it's, because then that's a huge onerous application process too.
Yeah, so what I found out, because I didn't understand why it couldn't. So apparently your malpractice insurance covers you based on where the patient's located. So that's the problem. So if your state doesn't or that state where the patient is doesn't allow a televisit, then our employers are very upset that we will be doing medicine without having malpractice insurance. So so hopefully that will change. There is a lot of legislation going on right now to make it sort of a whole US would be covered for telehealth, which is what needs to happen. Obviously, it happened during COVID because everything was suspended. And that's when we all realized we could do this. And then unfortunately it was taken away. The other thing I would say about multiple opinions is I've seen patients in the relapse cohort who are, have sort of exhausted therapies and are trying to get back on a treatment, and they're going through 5 or 6 different doctors and crisscrossing the country, and they're not getting treated. And their disease progresses, and they're getting weaker, and they're getting sicker, and obviously that potentially could be detrimental. So I think there's a balance of how much second opinion you need.
I think Dr. Chari's had a lot of great quotes now. The cure for anxiety, not more opinions. That's a good one. We should tweet that one out.
We have a number of other questions, and we're going to have another question session later. And a lot of you in the online audience have submitted questions as well. But we do have to take a break for a number of reasons. Dr. Chari will be heading to the airport very soon. Dr. Badeja will soon be visiting with his family. He's a native of this area. And Dr. Krishnan is going to be with us for the next half, and you've already gotten a preview of her talk. So with that, I want to thank you all for bearing with us in the beginning. I think you saw today that you were very, very, very lucky. You're unlucky to be here and have association with myeloma. But if you have that, you're very, very lucky to have seen the speakers you've seen this morning. They are exceptional. They are leaders in their field in the world. And one of the things that I always emphasize, it took me about 25 roundtables to figure out what makes these so valuable. And what I think makes these so valuable and why it's worth coming to them live is you will get insights here that you will never get from reading a paper, an article, or anything. You will get different opinions and views of how you should think about what you need. So with that, I want you to thank our faculty with me. Lunch, when you go out the door, we've got boxed lunches for you to go out. The lunchroom is on the other side of this air wall. And then we'll be meeting here again at 12:45.
Greg, can I just make two comments? So this afternoon, I am incredibly excited. We have two colleagues from City of Hope, Orange County, something incredibly unique to what we're doing in Orange County. Dr. Richard Lee, who is nationally renowned for integrative medicine. He's incredible. He was a Fulbright scholar, went to China to learn about integrative medicine, and has some incredible research and trials and things he's going to be doing at our cancer center in Orange County using integrative medicine to help treat symptoms of patients with cancer. So we're really excited that he agreed to come and speak. And then the other physician we have is actually recruited from MD Anderson, also unique to Orange County, because she answers the question that you guys always ask. Well, what exercise? You said do exercise. What exercise can I do? What are the other things I can do apart from chemo to feel better? And so she is a physical medicine rehab doctor who is going to talk about that exercise, bone health. What are the things you can do? And it's pretty unique that we have her as well as part of our Orange County Cancer Center. So I hope you all can stick around for that.